Welcome, everyone. It's the top of the hour, so we'll get started. I'm Dia Wagasback, and I'd like to welcome you to today's GlomCon seminar. Today, our talk is titled Targeted Disease Modifications in IgA Nephropathy. And we're very excited to have our speaker and panelists. So we'll start with this talk and then finish up with a case and some Q&A and panel discussion. So it should be a great session. Our speaker today is Dr. Jonathan Barratt. He is the lead for the IgA Rare Disease Group, the lead of the UK National Registry of Rare Kidney Diseases, and the Mayer Professor of Renal Disease at the University of Leicester. Our panelists today are Dr. Dawn Castor. She's an associate professor of medicine in the Division of Nephrology and Hypertension at the University of Louisville School of Medicine, and Dr. Sayna Norouzi. She's the director of the Glomerular Disease Clinic, the director of the GlomCon Glomerular Disease Fellowship Program, and director of the Polycystic Disease Clinic, an associate professor at Loma University Medical Center. And before we start, I'd like to wish a happy Mother's Day to all of those who are joining us here in the US. We are celebrating Mother's Day. So with that, and to make sure we have time for a good discussion and questions, I am going to turn it over to Dr. Barratt. And I will stop sharing.
Thanks very much. Okay. Just checking you can hear me and you can see my slides.
Yes, looks great.
Great. So it's a pleasure to join you again. I've given a couple of these before. I'm looking forward to the conversation afterwards to see whether people agree or disagree. So here are my disclosures. So I'm going to really base this around what's happened with the KDIGO clinical guidelines for IgA and really bring forward the kind of underlying concepts by which we now think about IgA nephropathy, and particularly what we thought about when we put these guidelines together with a particular focus on disease modification, because we're at an unprecedented time in the history of IgA nephropathy. For the very first time, we can actually give drugs that target the fundamental pathogenesis of this disease, rather than giving the sledgehammer CKD type drug approach. And that's what I think is really exciting about where we're heading in treating not just IgA nephropathy, but many different glomerular diseases with treatments that we'd always wished we could have had, and now they're actually becoming a reality. So one of the first things that we really focused on was trying to think about the relevance and importance of IgA nephropathy and to change the modern conception of what IgA nephropathy is all about. So if I asked anyone on the call from GlomCon, which do you think are the sexy, exciting glomerular diseases that you worry about, that you really do need to know about, because this can make people sick and put people on dialysis very quickly, or even just put people on dialysis? And my guess is you would probably come up with lupus and ANCA and TMA. Those are the supercars of the glomerular disease world. And when I ask you to think about IgA nephropathy, and if you went to any of the textbooks, perhaps you'd think about something like a car that I drive, which is clearly not that exciting. It's a small, slow car. You know, it's IgA is a disease that might put you on dialysis, but if it does it very slowly, and it doesn't do it very often. You don't really need to think very hard about IgA. It's a disease you don't need to treat early, because let's face it, you can bring the patient back in 2 years and nothing much has changed. And if you look at any of the textbooks, that's virtually what is written about IgA nephropathy. But data has emerged over the last few years to really challenge that notion. And in particular, there's data from the UK Rare Disease Registry, which is RaDaR. It's the largest rare disease registry in the world. And it has data on over 40,000 patients with a whole range of different rare diseases, one of which is IgA nephropathy. But if you haven't read this paper, I'd really recommend you take a look, particularly if you're interested in glomerular disease and other rare disease, because what this paper clearly shows is that if you have a rare kidney disease, you are far more likely to progress to kidney failure than the general CKD population. You have a much better survival because you're usually young with single organ disease, and therefore you are much more likely to be found on a dialysis unit or a transplant program than the general CKD population, who are much more likely to die a cardiovascular death before ever reaching kidney failure. And so this really put forward the idea that if we want to impact on our end stage population, we should really think about focusing on patients with rare kidney disease. And if you go and look at your transplant program, you go and look at the USRDS or any registry, you will see that a large number of patients with kidney failure have rare kidney disease, glomerular disease, PKD, other forms of kidney disease that would traditionally individually be thought of as rare and not significant, but collectively form the bulk of what we look after on a dialysis unit. And these are some data looking at IgA nephropathy compared to some of the other diseases in RaDaR. And you can see IgA nephropathy in that green color. And on the left-hand side, you can see the cumulative incidence of kidney failure. There is only one disease that has a higher cumulative incidence, and that's antiglomerular basement membrane disease. You then look on the right-hand side, and what we produced here was a graph where you can see there is some grayed out areas and a white area, and that we've called the therapeutic window. And that's defined by what we would typically say are the GFR criteria to get into a clinical trial. And what you can see here is, apart from anti-GBM disease, IgA nephropathy spends the least amount of time from diagnosis to stay within that therapeutic window. And the reason for this is many of the diseases that we're comparing it against actually do have safe and effective disease-modifying treatments. IgA nephropathy at the time these data were collected did not. And so we've summarized the IgA nephropathy specific data in this paper. And if anyone's heard me talk in the last couple of years, I will have gone through this data in great detail. And I'm not going to do that now, only to say that outcomes for IgA nephropathy in the UK are poor. At 20 years from diagnosis, 3/4 of the adults are on dialysis and half the kids are on dialysis. Now, it used to be that when we presented this, the general conception was, well, people with IgA nephropathy in the UK are a bit of a funny people, just like English people, they're a bit funny. And the UK nephrologists don't actually know how to manage kidney disease. That's why they do so badly. And there may have been something in that. But actually, what we see now with registry data from across the globe is that actually outcomes are as bad in other parts of the world, if not worse. We have data now in the last couple of years published from China, from Sweden. Sean Barber's going to be publishing his work from the Vancouver, BC data registry in Canada. John Sim has published, at least presented his work on the Kaiser data in California. All of these studies show equally poor outcomes in patients with IgA nephropathy. And then we have data from India as well. And the interesting thing with John's data, which we couldn't comment on in the UK, was his data on Hispanic patients. We just don't have a Hispanic population to be able to look at in detail. John's data suggested that the Hispanic population in his Kaiser data were one of the worst performing patient groups in his registry in terms of a high frequency of IgA and poor outcomes. So again, we're hopefully going to start to grow these data and look at different groups, different patient groups to help understand how this disease behaves in different populations within a country, but also across the globe. One of the big pushes is we can't treat IgA nephropathy unless we've got a diagnosis. And so we are heavily promoting the idea of an early diagnosis of IgA nephropathy, particularly because the data suggests that the lifetime risk of kidney failure is high, even at low levels of proteinuria, at levels of proteinuria where traditionally people might not have even thought of doing a kidney biopsy. So we want patients to be biopsied early. We want a diagnosis early so that we can give them disease-modifying treatments to prevent kidney failure in their lifetime. The sad fact of the matter, however, is that when you look at these registries data, the typical GFR at presentation for a patient with IgA is between 50 and 60 mils per minute, which tells me they've already lost at least half their nephrons before I even get the opportunity to start treatment. So one of the challenges we're going to face over the coming years with all of these fantastic new therapies is how do we identify our patients early when they've got enough nephrons to save so that they won't ever spend their life any time on dialysis in their lifetime. But the fact is we are picking up patients late and we need to think about how we change that. The second concept, which is not peculiar to IgA, but we've articulated this very clearly, is that when you're sat across the consulting room with a patient with IgA, you need to think what's actually driving nephron loss if you want to stop them ending up on dialysis. And you need to tailor the medication to those factors. For IgA nephropathy, we have an immune complex mediated glomerular disease. That is that is the disease that is driving nephron loss from the very beginning of the disease. And as more nephrons are lost, you have initially adaptive and then you have maladaptive responses within the remaining nephrons that almost at some point will become self uh, amplifying and will cause loss of nephrons, irrespective of whether you treat the underlying disease. But the key thing here is you have two very different pathological processes, and they require very different treatment approaches. Now, of course, in the perfect world, we would diagnose patients at the beginning of this process when they hadn't developed any significant nephron loss. And therefore, the only thing we would need to consider treating is the actual disease itself. And indeed, that is possible because in countries that have urine screening programs, such as Japan, Taiwan, and South Korea, where all school children have their urine dipsticked every year, they have a real opportunity to intervene early and treat the disease before CKD is established, and therefore there would be no point. What would be the reason to give a CKD treatment if there is none of these established processes? And indeed, if you look at these countries, the use of those CKD treatments is far less than what we use in Europe and North America. As I've said, unfortunately for most of us on this call, IgA nephropathy is picked up by chance. And by the time our patients see us, they actually have established nephron loss. So we have no option but to have to think about treating that CKD aspect as well as the immune complex mediated kidney disease. And the third thought that goes through this kind of complete change in the paradigm of how we think about this disease is if we do truly want to treat the immune complex mediated nephron loss, we need to understand something about the actual pathophysiology of the disease. And there's been a fantastic amount of work really clarifying what we think is going on in this disease over the last decade. And so at a high level, when we think about this disease, this is essentially an immune complex mediated disease. We can measure the immune complexes in the circulation in patients. It's not a standard clinical test. We do this in the research laboratory, but we can measure those and we can see that these are elevated. The main substrate for this immune complex formation is a particular group of IgA molecules in the circulation, which are often seen referred to as Gd-IgA1. And this is a group of IgA molecules that carry changes to the sugars attached to the hinge region. It makes these IgA antibodies sticky. They stick to themselves. They stick to other serum proteins. And there are IgG and IgA antibodies in the circulation that can recognize these sugar changes and amplify immune complex formation. And perhaps most importantly, we have a lot of data now, which I'm going to review with you, that suggests that this Gd-IgA1 comes from the mucosal immune system, the immune system that lines our respiratory, gastrointestinal, and genitourinary tracts. Not the same site that we traditionally associate with antibody-mediated kidney diseases. We traditionally think that the antibodies of membranous, lupus, ANCA come from central lymphoid sites, from plasma cells within the bone marrow, within the central lymphoid system, not the mucosal immune system. And that likely is part of the explanation for why many of the drugs we've seen work so effectively in lupus, ANCA, membranous just don't really work very well at all in IgA nephropathy, because the cells that are producing these pathogenic antibodies are within a different microenvironment and therefore are responsive to different treatments. This occurs on a complex genetic background, and I'll talk a little bit about that in a minute. And we're getting better at understanding what that polygenic background looks like. And then when we think about what happens when these immune complexes hit the kidneys, there's a predominant mesangial cell response initially with mesangial cell proliferation, the release of pro-inflammatory factors that can drive recruitment into the glomeruli of inflammatory cells, predominantly monocyte macrophages. And in some situations, that can lead to uncontrolled inflammation and crescent formation. Far more common in East Asian patients than in my Caucasian patients that I look after. But equally, that mesangial cell response can promote a profibrotic response characterized by podocyte loss, glomerular sclerosis, and tubular interstitial inflammation and scarring. And of course, these IgA immune complexes can get across the glomerular basement membrane and add to this activation of podocytes and tubular epithelial cells. And all of these processes are amplified by activation of the complement system. And so when we look at what we've changed in the KDIGO guideline, and this is hopefully, it's with Kidney International at the moment. I hope it will be in press within the next month or so. Our focus is very clearly, we want to prevent kidney failure in the lifetime of our patients. So we need to diagnose them early and intervene early. If we are going to approach treatment, we need to think about the two factors driving nephron loss, the IgA nephropathy specific factors due to the immune complex formation and deposition within the glomeruli, and the fact that if our patients are presenting late, we need to manage those CKD processes. And what the radar data and other registry data tells us, we need to get the loss of kidney function down as close as possible to the physiological state if we are going to make any headway in preventing kidney failure in the lifetime of our patients. And that's because these patients present young, with a lot of life ahead of them, and already with established loss of nephrons because they've presented late. And so what should the approach be, and what are the approach we're trying to promote? Well, the first is if you want to treat an immune complex mediated glomerular disease, then address the immune basis of the disease. And we now have treatments that allow us to do that. That's the nirvana. That is exactly why would we not want to switch off the immunology of the disease to treat this disease? That's what our aspiration is in membranous. It's what our aspiration is in ANCA, in lupus. We want to switch off the production of pathogenic antibodies and stop the disease. Unfortunately, what we're oh, by the way, if you haven't been to Leicester, that's not what Leicester looks like. But it is, I hope, what GlomCon is going to look like in Hawaii later on this year. So I hope to see you there. Equally, this is not what Leicester looks like either. But this is what we end up having to deal with, is the mess that IgA nephropathy has caused in these young patients because they present with established kidney damage. And we have no choice but to have to resort to CKD treatments because they've presented late. Now, I wish I never needed to think about a RAS inhibitor or an SGLT2 inhibitor for my patients because I'd identified them early and I'd given them disease-modifying treatments, but we don't live in that world just yet. And of course, if we have to think about CKD, hand in hand goes management of cardiovascular risk. So the practice that we are going to have to follow in our current world is to manage both of these simultaneously. We cannot prevent kidney failure in the lifetime of our patients without managing both of these drivers of nephron loss. And so in terms of thinking about the immune and inflammatory drivers, we want to stop the IgA accumulating in the glomeruli. We may want to also switch off immediately that immune complex mediated injury. We don't know. We've not really thought about the disease in this way. We don't know how much inflammation we see on a biopsy justifies an additional treatment. That's work we need to do. And fundamentally, we need to reduce the formation of circulating immune complexes and switch off inflammation. And ideally, if we had the drug, switch off those profibrotic pathways. And of course, what that's going to mean is we're going to need to think about therapies that target immunoglobulin synthesis and or immune complex clearance. And equally, we're going to need to think about therapies that target inflammation and or fibrosis, just like we do with the other glomerular diseases we look after, but which we've not had to really think about in IgA nephropathy up until now. And of course, while we think about these drugs fitting into nice silos, it's becoming increasingly apparent that drugs do more than just one thing. And there's going to be lots of exciting data with repeat kidney biopsy studies and biomarker studies that might suggest a drug we traditionally think of just switches off antibody production may also have a direct anti-inflammatory effect and vice versa. So this is going to become very interesting in terms of how we think about selecting treatments. But for me, the process that I want people to think about is you sit in the biopsy meeting, you see a patient with a new diagnosis of IgA nephropathy. Your first thought is, I want to give that person a treatment to switch off IgA accumulation in the glomeruli. I'm going to look at that biopsy. I'm going to say, gosh, there's a lot of inflammation there. I think I need to get that under control immediately. I need to use an additional anti-inflammatory treatment, or perhaps there isn't that much. I don't need to think about that. And thirdly, and a distant third, I'm going to have to manage their CKD at some point, but it's not going to get in the way of me treating the reason they've come to me in the first place, which is an immune complex mediated glomerular disease. So what did we have in the guideline? Well, we had Nefficon and we had systemic steroids. Those are the two treatments we talk about in terms of managing the immunological aspects of the disease. And then in terms of managing the processes that are kick in due to nephron loss, we have these agents here. But of course, it's already out of date because you and the guys in the US now have it iptacopan approved, a factor B complement inhibitor, and atrasentan, a standalone endothelin receptor antagonist. These will have to go into the next guideline. And then we've got yet more drugs coming in terms of the clinical trials. And we're likely to see another drug approved for IgA nephropathy before the end of the year and another one in the first quarter of the year after. But what I want to focus on for the remainder of the talk is this new idea that we can truly modify the disease in IgA nephropathy. We can reduce the formation of circulating immune complexes, which we believe will lead to reduced IgA deposition and switch off that immune-mediated damage to nephrons. And this comes down to our understanding of the importance of the mucosal immune system and the fact that we believe this is the source of those IgA antibodies that fundamentally drive immune complex formation in this disease. Anyone who's ever looked after a patient with IgA nephropathy will be aware that mucosal infections and mucosal activation triggers episodes of nephritis, often manifest by visible hematuria. This was described very early on after the first description of IgA nephropathy, clearly supporting a link between the mucosal immune system and the nephritis of IgA nephropathy. Indeed, a particular form of IgA that is only produced at mucosal surfaces, called secretory IgA, we can see the levels of this form of IgA are increased in patients with IgA nephropathy. We can actually see this type of IgA deposited in the kidneys in patients. It's not the dominant form, but we can see it. And we know that the level of this secretory IgA goes up after episodes of vaccination and mucosal activation in patients with IgA nephropathy. We know if we measure in the blood IgA antibody levels against a range of different mucosal antigens, they are always higher in patients with IgA nephropathy than healthy controls, suggesting the mucosal immune system is overactive. It's generating a more robust IgA response than we see in health. And we looked at this in a little bit more detail some time ago, and we used Helicobacter pylori as a model antigen. And so we looked at the type of IgA in the bloodstream of patients with IgA nephropathy in healthy subjects. And what we found was that the IgA against Helicobacter pylori in the bloodstream was largely polymeric. And it's polymeric IgA that we see stuck in the kidneys in patients with IgA nephropathy. But we didn't see a difference between that proportion, polymeric to monomeric, between patients and healthy subjects. But what we did see was that IgA nephropathy patients had far more of this antibody in their bloodstream, and therefore they had far more polymeric IgA in their bloodstream than healthy subjects. We went on to look at the kind of IgA1 content of that IgA in these patients. And we did lectin binding, and the more lectin binding you have, the more Gd-IgA1 there is present. And so you see here the total IgA, you can see higher levels of Gd-IgA1 in patients. When we looked at the IgA against tetanus toxoid, a vaccine that's given through the skin, so it doesn't go anywhere near the mucosal immune system, no difference in terms of the amount of Gd-IgA1. But when we looked at the IgA against Helicobacter pylori, a mucosal antigen, we saw very high binding of the lectin, suggesting this IgA contained lots and lots of Gd-IgA1, but again, no difference between healthy subjects and patients with IgA nephropathy. So putting all this together, what we can see is that in health, the IgA you produce against mucosal antigens is polymeric, and it does contain high levels of this Gd-IgA1. But in health, very little of that gets into your bloodstream. However, in IgA nephropathy, it's really a release of this mucosal IgA into the bloodstream that is the issue. It's not that this IgA is completely different to what we see in healthy people. It's the same type of IgA. It's just more of it is leaking into the bloodstream. And this reflects what we've been looking at in the laboratory, which is the microenvironment within which the IgA is produced heavily determines what that IgA looks like, whether it's monomeric or polymeric, how much sugars there are on the hinge region. And we can play around with IgA producing human B cells in the laboratory and alter different cytokines in the culture conditions and generate different types of IgA. And indeed, when we looked at the genetic basis for this Gd-IgA1 within the circulation, we found a very strong hit with the gene for the enzyme that actually puts the galactose onto the IgA1 hinge region. But the genetic or the SNPs that we found were not within the coding region of the gene. It didn't mean that this protein was somehow different. It was in the promoter area of the gene, suggesting this protein that this gene was more easily or less easily switched on and active in these patients. Again, consistent with the fact that actually in IgA nephropathy, there may well be some genetic basis and a microenvironment that promotes the production of this IgA and its release into the circulation that healthy people don't have. And so there's been a lot of focus on the mucosal associated lymphoid tissue. And this is highly specialized lymphoid tissue that we only find within the mucosal immune system. So what is the evidence really supporting the mucosal immune system as being the source of the problem in IgA nephropathy? Well, this is where the genetic studies come in. And if we think about what a genome-wide association study is, it's essentially just taking thousands of patients with disease and usually hundreds of thousands of patients without disease. It's looking at single nucleotide polymorphisms and simply saying, do we see certain SNPs more commonly in the disease group compared to the healthy group? It's a very simple test, but it's clearly doing that many, many, many times with all the SNPs associated with the human genome. And this was the first large meta-genome-wide association study that was published. It's over 10 years now. And I just want to draw your attention to this particular aspect of the analysis. So what Christoph did, he took all of those SNPs, all of those genetic risk alleles that were more commonly seen in patients with IgA nephropathy, and he said, do they just randomly associate with different processes in the body, or do they actually all congregate around certain biochemical processes? And this is the analysis I'm showing you here. And the most enriched pathway in this analysis was the intestinal immune network for IgA production. So all of those genetic risk alleles that we saw more commonly in patients with IgA nephropathy, a large number of those associated with the production of IgA within the intestine, really supporting the fact that IgA nephropathy is a mucosally driven disease and the intestine plays a large role. And this has been updated now a couple of years ago. And again, I just want to draw your attention to one aspect here. And in this analysis, that intestinal immune network for IgA production was reconfirmed. But there was an additional analysis to say, okay, for the genes that we know are dysregulated, where are we most likely to find them expressed? And you can see in this top right-hand panel, lots of individual immune cells, quite obviously, but actually tissue level, it was the mucosal immune system and it was the gastrointestinal tract. And you can see here the rectal mucosa, stomach mucosa, and small intestine. Interestingly, not the respiratory tract, not the genitourinary tract, but actually the intestine, again, was the organ system in which the genes that we're finding from the genome-wide association studies are most expressed within, again, pointing to the importance of the gastrointestinal tract in the generation of IgA nephropathy. Now that's the genome, but we know that we can regulate the expression of genes with epigenetic mechanisms. And one of those are microRNAs. And microRNAs essentially silence the translation of mRNA to protein. So they give a layer of complexity on top of what your genome is telling you. And they're just going to show you a couple of pieces of data. So this is data with some Chinese colleagues who were actually interested in diabetic nephropathy. And they've been looking at this microRNA 23B, and they thought it was important in diabetic nephropathy, so they knocked it out in a mouse. And to their surprise, the mouse developed IgA nephropathy, which they were really confused about. But when they looked in more detail, what they found was this particular microRNA was heavily involved in regulation of IgA production within the mucosal immune system of the mouse. And we went on to modulate this mouse with a variety of drugs, and were able to show we could modulate the development of IgA nephropathy by modulating this particular microRNA, suggesting again that the mucosal immune system has an important role to play in the generation of the IgA that ultimately ends up in the kidneys. And it's dictated not only by the genome, but also by the regulation of that genome within the mucosa. And the other thing that really is fascinating is the relationship between the frequency of these genetic risk alleles for IgA nephropathy. And here you can see worldwide pathogen diversity. And what this is starting to suggest is that people accumulate these genetic risk alleles because it helps them fight pathogens in their local environment. The downside of that is, of course, that they end up with the risk of developing IgA nephropathy later in life. But from a genetic point of view, as long as you live into your reproductive ages and pass on your genome, evolution doesn't mind if you die in your 40s of kidney failure because you've done your job and passed your genetics on. And this is very similar to other diseases we're seeing. So if you think about ApoL1, you can see here the frequency of the risk genotypes and the fact that these risk genotypes protect against sleeping sickness. So the fact that you're able to survive sleeping sickness, pass your genes on, but you develop a kidney disease later in life is something that we've already seen occurring, and that could be what's happening in IgA nephropathy. And this brings us now to a very interesting area, which is what is the interaction between the mucosal immune system and pathogens and the microbiome that we all have. We know from experimental animals that if you wipe out the microbiome, these experimental animals that develop IgA nephropathy no longer develop IgA nephropathy. So there's an essential interaction between the bacteria living within the gut and the mucosal immune system that generates the IgA that ultimately gets deposited in the kidneys. And this is largely driven through pathogen-associated molecular patterns that are recognized by pattern recognition receptors. You can see here perhaps one of the PAMPs that you'll know best is LPS, and from pattern recognition receptors, perhaps the ones you'll know best are toll-like receptors. These toll-like receptors are expressed on many different cells within the mucosal immune system, because of course the mucosal immune system is the first thing that comes into contact with invading pathogens. They have to be ready, they have to be able to recognize there's a pathogen, and they have to be able to deal with that pathogen. And this is some really fascinating data looking at these different interactions. And here you can see that bacteria, through this particular pathogen-associated molecular pattern, CpG deoxynucleotide, can modulate the way the mucosal immune system produces IgA. Actually, it can do it directly, but it can also do it through an intermediary cell. And here, BAFF and APRIL, which I'm sure you've heard lots about, are very important. And BAFF and APRIL have an incredibly important role within the mucosal immune system in driving the IgA response. And what's even more interesting is that these bacteria can communicate through this pathway and alter the way the IgA is glycosylated. So why might bacteria want to reduce the amount of glycosylation on an IgA molecule? Well, the reason for that is that bacteria generate enzymes that digest IgA, and they digest IgA at the hinge region, and that's where the sugars are. And if you take away the sugars, the hinge is more accessible and more easy to cut, and that means the bacteria can evade the IgA. And so we know that a range of bacteria have IgA1 proteases, and that will inactivate the IgA. And what's interesting is the largest number of bacteria in the large bowel, and in the large bowel, the amount of IgA2 that's produced is much higher. And IgA2 lacks a hinge, lacks that susceptible area that can be cut by these enzymes, and that's likely the reason. But of course, we know IgA2 is not important in IgA nephropathy. This is an IgA1-driven disease, and that's why we are very interested in the small bowel rather than the large bowel. And so we have this dynamic here. We have bacteria that are communicating to resident mucosal immune cells. They can modulate the amount of IgA. They can modulate the amount of IgA glycosylation. And they could be driving the excess of that Gd-IgA1 we see in the circulation. But equally, bacteria can develop enzymes that strip the sugars from the IgA once it's secreted, and that IgA can move back into the bloodstream. So we've got a really interesting dynamic here. We've got genetic basis, genetic studies that really strongly support the role of the mucosal immune system in IgA nephropathy, and we're getting emerging data that the bacteria that are within our gut can actually influence the IgA immune system and promote the production of IgA that ultimately can cause IgA nephropathy. And it's likely that it's this balance between the underlying genetic control and the microbiome that determines how much of this IgA appears in the circulation. And we're already starting to see studies where we're seeing differences in the microbiome in different mucosal sites in IgA. And so I hope I've convinced you that if we want to take a targeted disease-specific approach to treat IgA nephropathy, a very good place to start would be to think how we might be able to manipulate the mucosal immune system, because this seems to be where everything is being driven from, and in particular, the mucosal immune system of the gastrointestinal tract. And that's where the first drug ever to be approved for IgA nephropathy comes in, and that's Nefecon. It's a very particular formulation of the steroid budesonide that is specifically designed to only release the budesonide in the terminal ileum, which has the highest concentration of IgA secreting cells within the gastrointestinal tract. And it does that such that the concentration of budesonide is sufficient to be able to impair those cells and impair the production of mucosal IgA. And so we've had a phase 2 study of Nefecon in IgA, and we've had a completed now phase 3 study. And importantly, we've undertaken biomarker work to look at how the drug actually achieved the clinical efficacy that was reported in the NefIgAN and the NefIgArd trials. And so if we quickly look at the data, what you see here is the trial looked at a 9-month treatment course of Nefecon. And while the patient was on the treatment, you can see the patient actually didn't lose any GFR. But this was a 9-month treatment over a 2-year period. And when the treatment was stopped, you can see in the right-hand panel, the proteinuria came back, and you can see that the GFR started to decline. So this treatment is not curative for IgA nephropathy. While you take the drug, you are suppressing the mucosal immune system and you are suppressing the disease. But immediately you stop the drug, the disease is coming back, as you might predict, because we wouldn't imagine that Nefecon would irreversibly influence the mucosal immune system of the gut. It's relatively well tolerated. There is some systemic budesonide absorption, and so there are some steroid-related side effects, far fewer than you would expect to see with systemic steroids. And actually, the side effect profile was such that most patients, in fact, the vast majority of patients, completed the treatment cycle, and there's now data on a second treatment course in the open label extension showing the safety and efficacy are similar with the second course as they are with the first course. So what we wanted to do, because we're in the era of precision medicine, and we are kicking and dragging some of my colleague nephrologists through this in terms of treating glomerular disease, but we need to know what we're actually doing. We have a drug, I've shown you the rationale. Does it actually do what we think it does? Does it impact on immune complex formation? Does it impact on that Gd-IgA1? Does it impact on the mucosal immune system of the gut? And so this is where we've now published these data and we've presented data from the NefIgArd trial. And so first of all, what does this drug do to immune complex formation? And you can see here that 9-month treatment leads to a significant reduction in circulating IgA immune complexes. But what's perhaps even more intriguing is that when you take those immune complexes and you perform mass spectrometry, and you look at what's in those immune complexes, treatment with Nefecon actually alters the protein composition of these immune complexes as well, and makes them less likely to promote inflammation and fibrosis. We need to replicate this in the phase 3 study. We haven't done that yet, but this is data from the phase 2. What does it do to that Gd-IgA1? Well, it reduces the level of Gd-IgA1, and you can see here from the phase 2. What I'm going to show you here is a recent poster of the phase 3 data. So we've now analyzed these biomarkers in the entire NefIgArd cohort. And what you can see here is that treatment with Nefecon significantly reduces those Gd-IgA1 molecules at 3 months, 6 months, and 9 months. They return off treatment to their normal levels. We can see similarly reductions in the levels of immune complexes, and we report here reductions in the levels of IgG antibodies that recognize that Gd-IgA1. This is all in the context of having no effect on total IgA and IgG at the same time. So this is a highly specific effect on those key pathogenic biomarkers that we believe reflect mucosal activation. So how can we look at the impact of this drug on the mucosa? Well, we didn't do gut biopsies. This is all indirect measure. We looked at secretory IgA in the phase 2, and we saw a reduction in secretory IgA, a modest reduction in secretory IgA in the phase 2 patients with no effect on total serum IgA. And we looked at the IgA against certain antigens that would only be seen in the gut. And here's just antibodies against casein, so a milk protein. And what you can see is that treatment with Nefecon significantly reduced the levels of IgG and IgA against a dietary antigen, while having no effect on tetanus toxoid IgA. And we're going to present much more of these data later in the year on the entire NefIgArd cohort. We also wanted to look at the changes in chemokines and cytokines in the circulation that might reflect an impact on the mucosal immune system. We measured between 100 and 150 different factors, and this is a protein-protein interaction network looking at those proteins that were dysregulated by treatment with Nefecon. And you can see that they're very closely related. And when we do an analysis similar to the genome-wide association analysis and look, are these proteins associated with particular pathways, you can see what comes up. Exactly the same as the genetic study. When we look at the proteins that are modified by Nefecon, they congregate around the intestinal immune network for IgA production, being consistent with the fact that this drug is targeting the mucosal immune system of the gut. And these data, the nodes in red, are those that we've validated so far in the phase 3 total data set. And so, of course, we won't expect Nefecon to alter your genome, but actually I've mentioned already the importance of microRNAs in terms of regulating the expression of genes. And here, this is a separate study. We've just published this in KI, not the Nefecon data, but the actual work we did looking at these microRNAs. And what we found were 2 microRNAs were dysregulated in patients with IgA nephropathy who had progressive disease. And what you can see here is we looked at these in patients treated with Nefecon. miR483, no effect of the drug on 483 expression in the circulation. However, a significant suppression of miR122, which was interesting and unexpected. But miR122 is known as a fibromir. It's produced by the liver, and it's been strongly associated with the development of kidney fibrosis. And because Nefecon has high first-pass metabolism, which means it's metabolized within the liver very quickly, it's not unreasonable to think that actually one of the effects of Nefecon could be to suppress the liver production of this microRNA, and that could in turn have a downstream positive effect in the kidneys. We're investigating this at the moment. So within the kidney itself, I just want to draw you back to one of the new drugs that's been approved, iptacopan. So this is a small molecule inhibitor of factor B, which is an important component of the alternative pathway. And as I'm sure you know, most complement proteins are predominantly produced in the liver. And so we look to see whether that initial first-pass metabolism could impact on proteins of the complement system. And these are data we presented at the ASN last year. And what you can see here is that treatment with Nefecon significantly reduced the circulating levels of complement factor B. Now, we're working through at the moment analyses to look at the implication of that in terms of complement activation. But this comes back to that idea that I was talking about, where you think you have a drug that does one thing, and actually it may have multiple different effects that could be beneficial. An effect of Nefecon on reducing pathogenic IgA production, but an impact on complement could have a direct anti-inflammatory effect within the kidney. We need to prove that, of course, but these are the kind of data that are going to open up, I think, how we think about drugs being used in glomerular disease. And so coming back to the guideline, I want to reinforce the goal for us as nephrologists should be no patient with IgA nephropathy ever sees a dialysis machine. To achieve that, we need to treat the cause of nephron loss, and that's going to require different approaches depending on when the patient presents. And we're going to have to achieve physiological aging of the kidneys if we're going to get close to preventing kidney failure in the lifetime of our patients. This is the paradigm I think we should work to. First and foremost, we treat the disease. Yes, we come in with CKD treatments, but that's not how you treat an immune complex mediated kidney disease. And I hope I've shown you that there is a logic rationale behind targeting the gut to treat the kidney, and that actually the drug we have is the first truly disease modifying therapy we have available that we can use to treat patients with IgA nephropathy. Has shown clinical efficacy, but importantly, we've been able to show that it targets those specific pathogenic pathways that operate in this disease. And I hope what we're going to see going forwards is for each of the new therapies, a similar story unfold, where there is justification for the clinical data with data from biomarker and repeat kidney biopsy studies that show what the drug is achieving, because that's going to help us decide how we might combine these drugs in the future. What biomarkers might tell us who's going to be more sensitive to one approach rather than another. So thank you very much for listening, and I'm happy to take any questions.
Thank you, Dr. Barratt, for an excellent talk. Before we get to our case and the additional Q&A, there's a couple questions we wanted to direct to you. So one, can you just reiterate how it finds its way into circulation? I know you talked about it, but can you reiterate that point of how we think it finds its way into circulation, the IgA?
So that's a great question and one I don't know the answer to. We don't know. So there is a study coming out that I'm part of that hopefully will come out in KI, where we've actually endoscoped patients with IgA nephropathy for research, and we've taken bowel biopsies, and we've looked at the IgA in the secretions and the IgA in the blood at the same time. And it's by getting access to those gut biopsies that we are going to delve into what is the actual reason the IgA is going in the wrong direction. And we just don't have an answer. The genetic studies don't give us a clear answer, but I think it's going to be the tissue that's going to make the difference. And for the first time, we have a significant number of small intestine biopsies from patients with IgA nephropathy. And if we can use modern technology, we may well get to the answer of that question. But at the moment, we just don't know, I'm afraid.
Okay, excellent. Thank you. And then a question I had was if we know the levels are changing with different environmental triggers, right? And there's the potential to target it still, do we need to rethink how, especially with other drugs on the market, and maybe we'll come more to this, rethink how we're dosing a gut-directed therapy if we know we have elevated levels at certain times, and maybe it's a dose at the time of an infection or dose at the time of an immunization, those type of things. Is that something we can be thinking about for the future potentially?
Yep. So that's another great question. I think I'll take that in two parts. The first part is if we actually believe it's the microbiome that makes all the difference, perhaps we're not targeting high enough yet, even. Perhaps probiotics might help. And if we altered the microbiome, perhaps we'd switch off those triggers that ultimately lead to mucosal activation. And so we've just completed a study where we have dosed patients with a defined probiotic, and we're going to see what happens. We're going to see whether that might change things. And then I've forgotten the other question. That's how old I'm getting. Just remind me what.
So then my other part of that was then, will we rethink how we dose potentially a gut-directed
Yeah.
steroid?
I honestly believe that we do have flares of nephritis in IgA nephropathy. It's not this kind of single straight line, because it is a disease of young people. Young people have kids. We're celebrating Mother's Day. Mothers, I'm sure, enjoy every time their child brings home that lovely little infection that's going around school. So, younger adults are getting continually hit by mucosal infections. And we are doing a cohort study where we are particularly around loin pain, because I think loin pain is a reflection of a flare of nephritis and a flare of inflammation. So we're going to bring patients up when they've got this loin pain as a surrogate for a flare of inflammation, and we're going to bleed them and take every bodily fluid you can think of, and we're going to scan them, and then we're going to bring them back when they feel completely well. And the idea is that perhaps what we might do in the future is we might provide our patients, rather like we do with our nephrotics, with some urine dip. And if they are coming and they feel they've got a cough or a cold, or their kids are coming home and they dip the urine and there's a flare of protein in the urine or potentially blood, that might be an indication that they're having a flare of disease. And they might just need a 5-day course of an anti-inflammatory. And that anti-inflammatory could be a low dose of a systemic steroid, it could be iptacopan. But they might just say, okay, I've got a flare. Mucosal infection is going to go away. We know it goes away. We don't need anything for that. But while there's that flare, I want to protect my nephrons. So why don't I just take a 5-day course of an anti-inflammatory? And of course, that's way ahead in the future. But we're starting to do work to see whether there might be a rationale for that approach.
Thank you. Well, there's some more questions, but let us get to Dr. Norouzi to present the case, and I'm sure we're going to answer some of those during that.
Okay, let me share my slides. Okay, perfect. Thank you so much, Dr. Barratt, for the fantastic talk. And we are going to talk about, I'm going to present a case. We really want to keep this interactive today. So please keep the questions coming, because the landscape of IgA nephropathy is changing so fast. And as clinicians, we always have questions about how we should manage these patients, which medications, or should we start with one combination therapy? So I'm going to present a typical case that you might see at your GN clinic or in your clinic on a daily basis. And let's talk about it. And please just put your questions on the chat, and we would love to keep this interactive. So this patient is a 43-year-old Hispanic male, and he has biopsy-proven IgA nephropathy. He got his biopsy done 4 years ago. He has history of CKD stage 2 4 years ago, and now his CKD has progressed to CKD stage 3 as of a year ago. He was diagnosed with hypertension. He was diagnosed about 5 years ago, and his blood pressure is really well controlled. His current medications, he's taking benazepril 40 milligram daily, and this is the maximal tolerated dose for him. His eGFR currently is 39, his UPCR is 1400, and his creatinine is 1.78. So this is his biopsy that we have from 5 years ago. As you see, it's a good biopsy. He had 10 to 15% EFTA. He had mesangial hypercellularity, as you see, M1, no endocapillary hypercellularity, so it was E0, and he doesn't have any crescents, so C0. And he has some segmental sclerosis on his biopsy as well. And as you see, this is his IgA in his mesangium, and the rest of his IF was negative. These are the mesangial deposits on his biopsy. His GBM was normal, and he had some partial food process effacement as well. So basically, our pathologist called this as IgA nephropathy with segmental sclerosis. His MESC score is M1, E0, S1, T0, C0. So this is, as I said, a typical case that you might see during, when you're sitting in clinic. And then with everything that we talked about IgA nephropathy today, and the treatment landscape that we know that we're going to have new medications as well, we'd like to start a discussion about how to manage this patient, and what your opinion as a first-line treatment for this patient who's coming to your clinic, hoping to prevent dialysis for the next few years, or, he has CKD stage 3 as of now. So would love to start the discussion.
Okay, so this guy's in trouble, isn't he? He's young. He's got a GFR of 39. You haven't got time to wait, is the first thing to say, in my view, because he's hopefully going to live for another 40 years. So if you just work out, if he loses a minute per year for the rest of his life, he is absolutely going to be on dialysis, isn't he? If we agree physiological stage. So the first thing to think is this guy's in serious trouble. And it's not going to happen next week, but he is at real risk of ending up potentially in his 60s on dialysis, which is, as someone who's getting close to 60, is a bloody nightmare because I'm having a great time. You know, 60 might seem old to some of you young people, but it's not old, I promise you. So we've got to think very carefully. And I think people can get very phased by all of these new wonderful drugs. I take it down to the basics. I want to treat his IgA nephropathy. That's one. And two, I have to treat his his chronic kidney disease because he has it, and I have to treat his cardiovascular disease because he's going to die a cardiovascular death if we don't watch that. So we've got to think about those three things. Now, you're not going to be able to start all of those drugs in the same sitting because he'll just walk out and think, what the hell's going on? And he might not take any. So for me, my view is IgA nephropathy does not disappear. It does not go away. He always will have IgA nephropathy, so I want to treat him. So for me, I would be giving him Nefecon because it's the only drug I've got that is truly disease modifying at the moment. I would be wanting to maximize his CKD treatment, and he's on benazepril. He's got good blood pressure, but an SGLT2 inhibitor would seem an obvious choice. You might want to think about, would you give benazepril or would you swap that for sparsentan or would you add an ERA? I would do that in a sequential approach because each of these will drop his blood pressure and you don't want him to fall over. And I would manage his cardiovascular risk and, you know, really go to town on what is his cholesterol, all the lifestyle measures. And then I would explain to him the reason for doing that. And I would watch this space and I would watch to see what kind of response he got. But the key thing for him, who's had a disease for 5 years, and then suddenly someone's getting all excited about it, is what's going on here then? I've had the disease for 5 years, everyone's been happy, and now you're suddenly telling me I should be really unhappy and really worried about the disease. That's a real difficulty because if this guy does not buy into what you're trying to do, he is not going to do what you want him to do. And there's been this 5 years of inertia because we quite frankly didn't have anything else, but we're going to have to make sure he understands, and it may take 2 or 3 visits to get him on board. But that's going to be the important thing, is to get him to buy into the fact if we do not proactively manage his disease, he will in all likelihood end up on dialysis at some point in the near future.
Thank you, Dr. Barratt. So to summarize, you're going to start him on Nefecon today, and then you're going to have him to come back after a couple of months to switch his ACE inhibitor, and you're going to start him on SGLT2 inhibitors as well. And then he come back in a couple of months to switch his ACE inhibitor to either sparsentan or atrasentan.
So what I would do in clinic is I would start him on Nefecon today. I would give him an SGLT2 inhibitor to go home with, but I wouldn't have him start 2 new tablets on the same day, because if he doesn't like one of them, I'm not going to know which one. So I will do that. I actually do most of my treatment, my management by phone. So I'll give him a call in 2 weeks, find out how he's managing. And then I'll perhaps give him a call 4 weeks later. If he's managing okay, I'll start the SGLT2 inhibitor. And we know from the data, we won't expect to see a change in proteinuria for at least 6 months. So you've got to manage his expectations, and you've got to manage your own expectations, that the phase 3 data didn't show a difference between placebo and treated until 6 months. And I would then be checking his bloods, expecting to see no difference in 3 months, and potentially some difference in urine at 6 months, and more likely at 9 months and 12 months. So as a nephrologist, you have to manage your own expectation about what you're likely to see. And at the same time, if he goes on to Dr. Google, he'll be wanting to see his proteinuria disappear. And if he's not seeing that happen, he may just decide not to take his tablets. So again, it's about educating the patient about what to expect.
Thank you so much. Dr. Castro, I would love to know your opinion about this patient as well.
So this made my life really easy because I completely agree with the stepwise approach. I also really like the point about how our management has changed. So my management has changed, and I have patients that I've actually in follow-ups had said, you know, we used to be happy with less than 1 gram. The guidelines have changed. I'd like to offer this treatment, say they're sitting around 700, 800 milligrams a day. They're still not at goal. So I actually just had this conversation with a young patient of mine who I recently started on targeted release budesonide or Nefecon because she was still sitting around 800 milligrams, and she said, "Wait, you always told me 1 gram was the magic number." And I think she appreciated that I was staying up to date and that these are new guidelines, and the guidelines are based on new knowledge of lifetime risk in patients even with low to moderate levels of proteinuria.
I have a question. So if there's complement on the biopsy and you have iptacopan, where does that come into your management of this patient?
I think that's a great question. I think for me, the use of complement inhibition, I've often used it in patients that didn't have adequate responses, that I've already tried a round of, either budesonide or systemic steroids. Additionally, if there's a lot of inflammation on the biopsy, so this gentleman just had like an M1 lesion. I mean, I know the data on biopsy is controversial because the clinical trials didn't require a biopsy close to the time of enrollment, so it's hard. But just from what I've seen, if you have someone with more inflammation on biopsy, I think that kind of triggers that. It is a little bit trickier because patients, have to get vaccinated. They have to be on prophylactic antibiotics. So it is a bigger ask of our patients, but it is a great tool. And so far, I've seen some incredible responses.
Yes, thank you. And then another question, and I think this goes back to partly my question that I asked you, Dr. Barratt, earlier. It's lifelong. We give the Nefecon for 9 months. Then what do we do?
Oh, sorry.
Oh, no, I was gonna go ahead.
So in my practice, I would watch the patient and monitor the proteinuria. And we certainly had people in the phase 3 whose proteinuria came back quite quickly, and I would give them a second dose. And we still have people in the phase 3 that proteinuria still hasn't come back. So we know IgA is a very heterogeneous disease, so I would monitor the proteinuria. In the US, you guys are doing a study called NephExtend, which is actually looking at adding an additional course of Nefecon after you've completed your first 9 months, looking at safety and efficacy. So I think that's going to be really informative. But of course, what we know is that this is a lifelong disease. We have no cure, and we are going to have to balance the risks of giving a continual therapy against the benefits. And I think we're just at the beginning of a journey. We're at the beginning. If you think what happened with vasculitis, to be quite honest, we had the tools, but we're still thinking about what the right induction regime and the right maintenance of remission regime is, and when should we stop the treatment. We're still working that out, and I think that's where we're going to be over the next 5 to 10 years in terms of how we use these drugs.
Yeah, and just to add on to that, those are great points, and certainly everybody's individual, so they're different. So I've extended treatment on patients who maybe started out with nephrotic range proteinuria, and I'm already seeing a very good response at 9 months. But say they still have 1 to 1.5 grams, and I want to see that go down further before stopping treatment. So I've actually tried to extend the therapy. And then I've had some patients that shockingly go into complete remission and are still in remission 2 years later. I've had others that I've redosed, a year after that initial 9-month course. So everybody responds differently, which is great job security for us because we can't protocolize anything. But, I think we really just have to take a look at each individual, and extended dosing or redosing are certainly part of that.
I wanted to add that I have patients that the same thing, that sometimes you have to continue Nefecon for a longer time to achieve that remission. And I've had patients that I've stopped Nefecon, and then I see that the protein is bouncing back, and I had to restart Nefecon at some point as well. To the point of Dr. Barratt that he mentioned that he's going to add atrasentan or sparsentan at some point as well. I do have those patients as well that they are receiving combination therapy of Nefecon and sparsentan, and recently atrasentan is available as well. So that kind of is my approach as well. So we have a question about the rebiopsy, and I think this is something emerging as well. Like same as lupus nephritis, the more combination therapies that you do and then heavily treatments that you apply, then you want to actually taper down these treatments down the line. And to have a better understanding of the risk, like where do we stand, sometimes we might need to repeat the biopsy. It's kind of coming up on my practice with my patients that I feel like sometimes I really need to rebiopsy these patients at this point, and would love to get your opinion, Dr. Castor. I'm going to start with you. That are you considering rebiopsying these patients as well?
Absolutely, although we get different buy-in from patients. So I think that especially a patient that, is more than 5 years out, while I completely agree that this is a lifelong disease, there's a big difference between, someone that has just advanced fibrosis and, severe IFTA on their biopsy versus someone that has, active lesions. And the approach I would take to treating that patient. I probably would not use a complement mediated drug in a patient that mostly had fibrosis and had very little inflammation.
And I think that's interesting because I think there's been more and more questions that have come up of patient-specific cases too. But I think I've seen the opposite too, where there is a little bit more fibrosis, more advanced disease, but the complement is still present. And then the question was, do we try a complement directed therapy versus potentially one of the clinical trials where, may have some different outcomes. I think, like you said, this all stems back to educating the patient, right, too, and that knowing that we don't know everything and that we're going to work through it and things are going to change. Just as their disease course is going to change, we're going to change our what we know and what we can help manage. And there's I think to that point, there was the last comment here in the chat was about, complement measurements in the serum are not useful in activity, disconnect from tissue deposition, and then we can readily access the circulating anti-GD1 antibodies too. And then, as we've heard in your talk, Dr. Barratt, those aren't even necessarily predictive of what we see in the tissue. So we're making great strides in progress, but what else can we do and use these tools?
I think in terms of the complement, you've got to be really cautious because it depends what you stain for in the kidney biopsy. So you mentioned complement still present. We know if you stain for C5 beta 9, if you stain for C3d, that's going to hang around for 6 to 12 months. So one of the things we need to rethink is staining the kidney for complement activation and knowing that actually what we're staining for indicates complement activation in the here and now. And certainly we don't have iptacopan available in the UK yet, but I would always be doing a kidney biopsy before starting a complement inhibitor because I need to know that actually the complement system is active and I can justify using a drug to target a process that is actually happening in the here and now in the kidneys. So for me, I think repeat kidney biopsies are going to become more common. I think particularly around the use of complement inhibitors. I think in terms of B-cell directed therapies, the IgA isn't going anywhere unless you can switch it off. What I'd love to do is have that kind of data that you have for C3G, is that I do a repeat biopsy to check for residual disease and all the IgA has disappeared. How cool would that be? So that's what I would hope we might want to do. And then we can justify stopping a treatment rather like, and I think we can learn a lot from the lupus literature in terms of how they use a biopsy to determine disease activity. Because I think one of the real challenges is interpreting proteinuria in the context of all these CKD treatments. because we are hemodynamically suppressing proteinuria, and therefore, is that really telling us how much glomerular injury is going on? Because we just can't see it because we've hemodynamically reduced the proteinuria and lost one of our best biomarkers. So I think biopsy is going to become increasingly important. And I think we should be offering our patients more access to biopsies to help us guide treatment until we get better non-invasive biomarkers, but we just don't have any on the horizon just yet.
Thank you. And then along those lines of monitoring, the question of you've achieved proteinuria remission, but there's still hematuria. What is your approach to those patients? Or the patient that presents like that with very minimal findings on the kidney biopsy. They're very young, they have no proteinuria, but they have some intermittent hematuria and no real inflammation that we can see pathology.
So this then extends this conversation out for another 3 hours, I think, in terms of the value of hematuria. I am very much a nihilist. So why would you biopsy someone with isolated non-visible hematuria, no proteinuria, normal kidney function? I wouldn't even consider biopsying them. We know I would never discharge them from my clinic, and I would follow them every year. But we know that we've done a study, people like that, 50% of them will have a normal kidney biopsy. The next commonest diagnosis is IgA, which shows no activity in terms of looking at histopathological changes, or it's a type 4 collagenopathy. So I would always monitor those people, but I wouldn't, unless they couldn't sleep at night or they needed a biopsy, because we occasionally see these people want to join the forces or the police force or the fire service, and they have to have a workup, and we will offer that. Or the other time is a live donor. But most of the time, these people, and so for me, that really tells you how important hematuria is as a biomarker of glomerular inflammation, is that these people have masses of hematuria, as in they have glomerular hematuria, they may have episodes of visible hematuria, but they have no kidney pathology. So why does hematuria suddenly take on this mantle of being a fantastic biomarker later on in the disease when it's actually the same amount of hematuria means nothing in a large number of patients? So I have a real disconnect there, but I can tell there are other people on the call who believe differently. And it's great that people think differently, but for me, I wouldn't biopsy that person. I would monitor them.
All right, thank you. Thank you very much. We are a bit over, so I wanted to allow Dr. Castor or Dr. Norouzi to have any last minute questions or comments, and then we'll let Dr. Barratt have the final word.
No, I mean, I think he summed it up well. I think we don't really know for the persistent hematuria patient. Assuming this is a patient that had proteinuria, we've gotten that under control. I think following the GFR very closely, if that patient started to have a GFR decline, I may, consider trying to optimize therapy, or even, trying to do a more targeted therapy to see if that helped slow the progression, as well as helped address the hematuria. But I think we need more data, and part of the problem is the heterogeneity in how we look at hematuria. So how many people are looking under the microscope and seeing if there are red blood cell casts, for example. But great question.
If I'm treating a patient with a high grade of proteinuria, and patient's proteinuria is going down, but hematuria is all of a sudden is going up, or continue to have persistent hematuria, and if it's actually true hematuria, meaning like dysmorphic RBCs under the microscope, for this patient, I actually might re-biopsy this patient. I want to see how active the disease is, and I understand Dr. Barratt's point that it might come back as negative, but this is a patient that had high grades of proteinuria, and he got the treatment, but despite the treatment, hematuria is persisting for some reason. So it's kind of odd to me that for some reason, patient is responding from the proteinuria side, but at the same time, hematuria is persisting or getting worse. Other differentials might come to my mind that maybe I'm missing something about this patient, or I just want to know more about the what's the reason for this hematuria? Because hematuria is like sign of inflammation to me, and something is going on that is not getting treated appropriately. So this is one of those situations that I might discuss re-biopsy with my patient, just because I want to have a better understanding and adjust the medications based on that. Yeah, so that's
May I ask another question to that? Because there was Dr. Singh had put something in the chat earlier on why 1/3 of IgA nephropathies have thin GBMs. Do you do genetic testing in any of these patients if you do see that and you're thinking of potentially other causes?
I actually do. I'm a huge fan of genetic testing. I have a rare kidney disease clinic, so I do a lot of genetic testing for my patients, and it affects my how I treat patients. Actually, it affects my understanding of their disease situation as well. So, of course, if genetic testing shows me that they have other reasons for having persistent hematuria, of course, I'm not going to push for immunosuppressants, and that's going to justify the finding to me. So, I think genetic testing is something that we have, like as a nephrologist, we have to become more comfortable with ordering genetic testing and interpreting that, because it can help us a lot with how we are going to push for treatment for these patients, the prognosis of the treatment, and how about like an education, overall education to our patients about what they have and what they need to expect from receiving the treatment and what's going to be our goal in this situation.
I'd just like to add, like, especially if there's family history, when someone presents with hematuria, I jump to genetic testing. I think type 4 collagenopathies are way more common than we think. We're at the tip of the iceberg. And with IgA nephropathy being the most common glomerular disease, we're going to see more and more patients that have both of these things.
All right, thank you. And Dr. Barratt, we thank you for a wonderful talk, and Dr. Castor and Dr. Norouzi for participating and sharing your management and all of the questions and comments that we've had in the chat. It's been great, and as you said, we could talk for hours and hours, but I know a couple of us have some kids to get to today. So Dr. Barratt, any last words for us today?
No, I mean, this has been fantastic. It's great to catch up, and I look forward to seeing as many of you as possible at GlomCon later in the year.
All right. Thank you, everyone. Have a great rest of your day or evening. Appreciate everyone's time.
Thank you. Bye.